Welcome back to PICS-P. I'm Zach Hodges, a Pediatric ICU Fellow from UT Southwestern in Dallas.
And I'm Alice Shanklin, a Critical Care Fellow at Children's National in Washington, D.C.
Alice, what are we talking about today?
Today is part 2 of our post-intensive care syndrome series. We're talking about where we are as a field in detecting and preventing post-intensive care syndrome. Zach, who did you recruit to talk with us about this?
We're excited to bring back Dr. Elizabeth Killien for this part 2 episode on post-intensive care syndrome in pediatrics. Dr. Killien is an Assistant Professor of Pediatrics at the University of Washington and intensivist at Seattle Children's. She is a leading researcher and mind in the field, and we're so excited to have her back on with us today.
I found this episode incredibly galvanizing. Let's get right to the content.
So far, we've talked a lot about the complexities, and appropriately so, of the type of patients that are at highest risk for having negative outcomes after the ICU course and issues with completely delineating how effective they are. I just wonder, for our intensivists at the bedside, they might feel somewhat helpless. This patient who was really sick at baseline is coming in with a really severe illness, and they're trying to do the things to minimize pain and have appropriate sedation, but maybe almost feel like this patient is almost doomed to a poor outcome. My question is, do you feel like there are any particular action steps that next time we're at the bedside taking care of one of these critically ill children, what can we do at the bedside to reduce their risk of negative post-ICU syndrome features?
Yeah, I think that's a great question. What we think we know is that the more a child can get back to their typical routines as quickly as possible, the better. And so that does not necessarily mean that on day one they're up out of bed and walking through the halls. We know that a lot of our patients can't do that. But early involvement of physical and occupational therapy to mobilize, there's been a really nice multi-center evaluation of early mobilization in PICU patients that have shown some promising results. Minimization of delirium. We know a lot about, at least ideally, how we should be doing that. We don't always do a nice job of actually doing it, but sticking as much as possible to day and night schedules, minimizing to the degree that's safe the alarms that are going off in a patient's room, the assessments that are happening that disrupt sleep, and reducing as much as possible their lengths of stay. There's very consistently an association between length of ICU or hospital stay and post-discharge morbidity. And the things that add to lengths of stay that may not always need to are duration of mechanical ventilation. Sometimes we are the ones that are dragging our feet on that. Sedation management that perhaps is overdoing it, right? We certainly don't want them to be under-sedated, but we also don't want to be impairing their ability to separate from the ICU by over-sedating them. The ability for a family or child life or other support systems to be in the room, interacting with patients, orienting them to where they are. For older kids, there's been a lot of work done on things like during ICU reflections like diaries, art therapies, et cetera, to get kids to process their experience of being in that environment. These are all areas that have shown some real promise. We don't have a definitive answer of, if you do this thing, then you will absolutely improve their outcomes. We are not at the point where we're doing interventional studies, but, we're not far off. And I think that it is also a nice time to bring up the idea that assessing post-discharge outcomes has a role not just for knowing how the kid is doing in and of itself, but also for use as an endpoint in our trials of various medical therapies and interventions. So the SHIPS trial is a really great example of that. That's the steroids after pediatric septic shock study. And it's the first large multi-center interventional trial in pediatric critical care that is using a quality of life measure as part of the primary endpoint. And this actually developed out of some of the work that I had done with Jerry Zimmerman as a resident. Some of the work that I did was extraordinarily preliminary work for this study that he'd had in mind to do for a long time. And he first performed the LAP study, the Life After Pediatric Sepsis evaluation. And what that did is it just observed how kids did after severe sepsis and septic shock, and what was their quality of life after their hospitalization. And what he found was that say at a month, mortality for pediatric septic shock was about 8%, which is obviously one of the higher mortality diagnoses that we see in our ICUs. But if you looked at severe deterioration in quality of life at a month, now you are up to nearly 30% of patients had that.
Wow.
And then if you combined those two outcomes of did you have death or a severe deterioration in your quality of life, all of a sudden you had 37% of kids with septic shock having that endpoint. And so he used those numbers to develop sample sizes for an interventional trial that utilizes a composite outcome of mortality or severe deterioration in quality of life, rather than just mortality alone. And when you look at the sample size needed for an interventional trial, if you use mortality alone, you're talking thousands and thousands of patients. And if you use that composite outcome where you expect that over a third of patients may have that outcome, you all of a sudden reduce your sample size substantially into hundreds rather than thousands. And so he used that preliminary data to develop the SHIPS trial of randomizing children to steroids versus placebo for severe septic shock. And the primary endpoint is a composite outcome of death or severe deterioration in quality of life. And I find that a really novel way of incorporating morbidity outcomes into our research. That while we can certainly think of plenty of ways that we can optimize kids' recovery with mobilization and delirium prevention, et cetera, some of our more discrete medical interventions in terms of this medication or that medication, this procedure or that procedure, this way of ventilating a patient versus that way of ventilating a patient, can also potentially impact their long-term post-discharge outcomes, not just their in-hospital outcomes. And I think that's a really powerful area of upcoming research in the field.
Oh, yeah. If your outcome is something that matters and it can help you change your necessary sample size calculation, that's like awesome.
Exactly. It can make research much more feasible because one of the biggest limitations in interventional trials in pediatric critical care has been patient accrual. Over and over and over again, our interventional trials have been stopped early or have not demonstrated clear results because we don't have the sample size to power these studies enough for the outcomes that we have been using, which are things like mortality or in-hospital markers such as ventilator-free days, MODS development, etc. And if we can look at a post-discharge measure that, as you mentioned, Alice, is extremely important to a family, maybe even more so than something like ventilator-free days, and it can also improve our statistical power to be able to accomplish these studies with a more feasible sample size.
A lot of what you said certainly resonates with me as a trainee. I recognize that our mortality must be much lower now than it was a previous generation ago. And I see these patients who come back to the ICU with recurrent admissions, and you see them not quite at their baseline previously, and you can kind of see them maybe deteriorate over the course of your training. And the fact that trials are trying to incorporate these more long-term outcomes that aren't as, I wouldn't say hard, firm like mortality, but also quality of life sure seems important. As a patient is recovering from their critical illness, we've done the things that you mentioned so far to reduce their risk of post-intensive care syndrome, that being limiting sedation, trying to mobilize them early, avoiding prolonged intubations if all possible, many of these things. And we're getting you ready to get them out of the ICU. Do you have any tips for how we can set them up for success for their continued recovery while inpatient, and thinking about communication with the floor team or different therapies? What action items do you have here?
I think that communication is the first and foremost thing. We don't know what the best way is of making sure that these kids are followed, but for most current ICU structures, no one in the intensive care unit is going to be following this patient after they leave the ICU doors. It is very few and far between that pediatric intensive care units have follow-up programs for their patients. And so we need to make sure that the people who will be following those patients are aware of the range of morbidities that the patient may experience. That includes the floor team, but probably even more importantly includes the primary care teams. And the communication between ICU providers and primary care providers is often fairly limited. And so what we need to do better about is figuring out how to share that information with primary care providers. Because I don't think that most people would be surprised or particularly concerned that if the week on the floor that this patient is recovering and maybe just on some oxygen, remembering how to eat, getting their chest tube out, they still have some pain, they may be a little anxious, they may be still working on regaining strength and mobility. But what if that is still the same in a month or in 3 months? No one in the hospital is following that. And it is really on the primary care providers, who have so many other things that they're also trying to focus on, to be aware that this has happened to this child and that they should be on the lookout for not just their physical function and pain after an ICU stay, but also their emotional status. PTSD is incredibly rampant in both kids and families after an ICU stay. Social interactions. I think these are conceptually very important. What we don't know enough about, and one of the things that we're really trying to do now in the research world, is figure out how to operationalize some of those recommendations. So how do we actually communicate that information to primary care providers? Do primary care providers have the bandwidth to add more assessments to their already short visits? Is it better to share the information with the families so that the families are aware to be on the lookout for these? In general, obviously we want families to know that these could be risks that their child faces. On the other hand, we don't want to overstate it and kind of over-medicalize patient recovery and have families being worried every time their child doesn't want to get up and go play in the backyard. And so it's a balance, and that's something that we don't know from a research standpoint what the right answer is. But I think just from a common sense standpoint, we can say that the more people who know that this child is at risk for deficits in a lot of these areas is helpful. What we do about it is also, at this stage, just what we think is common sense. We're not at the point of having done interventions to see whether it actually makes a difference. But you can certainly foresee that ongoing outpatient physical therapy, psychological therapy, school supports, these are things that may be helpful. There's currently work being done through the post-ICU subgroup of PICS-P to look at communication with PCPs and whether incorporation of standardized screening may be helpful. Similar project is probably going to start soon to look at incorporation of school nurses into this post-ICU support system. So I think there's a lot of potential, but we just need to learn more about what's actually helpful and what's not. And I think that for folks interested in studying post-ICU outcomes, we're probably at a point where we can start to shift from just identifying that there are deficits to really identifying, A, which specific patients are most at risk, B, which interventions in the hospital may minimize that risk, and then C, what do we do after they leave the ICU that best supports their recovery?
Oh, absolutely. There are so many mental health screening recommendations in the AAP Bright Futures. I'm excited to hear that PCPs are sort of involved with the project.
Yeah, well, that's our hope, because we know that, again, most pediatric intensivists are very far removed from their understanding of typical child development, mental health screening and support, et cetera. And also many are not in a place that they want to be doing that follow-up. It's not their area of interest or expertise, and that's okay. I don't think that we need to assume that a standardized post-ICU follow-up clinic run by intensivists is the right model. It may be for some places, but I think there's a lot of different types of models for how to support kids after the ICU stay that we just don't know enough about. And that's really the next big step is what works best for kids and what works best for different institutions and healthcare systems.
It seems that our patients' ability to recover from their critical illness and reach their prior baseline is going to be very much dependent on how connected they are with the medical system as an outpatient, what resources are available to them in their community, what financial resources they have available in transportation to get to these various modalities. Certainly many social aspects that unfortunately aren't necessarily inside of our control in the walls of the ICU. You've mentioned a couple of times ICU follow-up clinics, and I'd like to know how you visualize their role in all of this and And perhaps which model of staffing these clinics do you feel like is most sustainable?
That's a great question. We do not have an ICU follow-up clinic here in Seattle, so it's not something that I've worked in personally. A number of institutions around the country are developing these clinics, and the ways that these clinics are set up is as variable as the number of institutions that they're at. So some of these clinics refer all of their ICU patients to the clinic. Some are just for a subset of patients.
Interesting.
And we can certainly say we think we know who may benefit the most, but I don't think we can necessarily say that only patients who meet certain criteria would benefit from post-ICU follow-up. We're definitely not there in our understanding of the risk factors for this. But at the same time, these clinics are just getting started. In many cases, are certainly limited in funding and resources, and saying that you're going to refer thousands and thousands of ICU patients to them every year is probably unrealistic. So I do understand that we need to limit it to some degree in certain circumstances. The types of resources that are available through these clinics may include an intensivist, developmental specialists, physical therapists, psychologists, neurologists. In fact, most of the work on post-discharge clinics has come out of the neurology world.
Nice.
Neurocritical care is probably the most well-established field that has looked at standardized post-intensive care, post-hospitalization follow-up clinics that in part is tied to post-traumatic brain injury follow-up, which has been reasonably well incorporated into a lot of different facilities. The other group that does a lot of standardized post-ICU follow-up is the NICU, actually. They really developed this far before the Pediatric ICU did, and so we may be able to learn something from their models as well. One of the things that I mentioned earlier is this multi-center study to validate the PICS-P criteria, and it's the Post-Intensive Care Syndrome in Pediatrics study. It's being run all over the country, and one of the hopeful outcomes of this study is to say we really have a much better understanding of exactly who is at greatest risk and in which areas. And so maybe the information from that study and others that are ongoing can help us focus the types of patients who would most benefit from post-follow-up care and the types of services that would be available at those. None of this addresses the problem of getting kids to come to these clinics, whether it's because of limited resources for the family to be able to do that, limited interest of the family to be able to do that, or a feeling that maybe the child doesn't have as obvious of deficits, which may or may not mean that they don't have any at all. And it certainly ties in with what the support services are through their typical pediatric care. If they feel very well supported through their primary care clinic, maybe they have less of a need for a second clinic at the tertiary or quaternary care institution where they were hospitalized. That institution may also be hundreds of miles away from their home. We certainly know a lot more about telehealth than we used to. And I do think that we as a field are going to need to incorporate more of those types of technologies into our ongoing evaluations and assessments of patients after they leave the hospital, because I think it is unrealistic to expect families to show back up in person at a clinic even once, not to mention multiple times to get serial assessments.
Oh, that's very fair. Dr. Killien, before we wrap things up, something that we do as PICU fellows is before a kid leaves after a long admission, when they get a floor bed and they're ready to transfer out, we usually go say goodbye to the family, examine the patient, and transfer them out. A couple of weeks ago, I was transferring out this awesome teenage girl, not intubated, very traumatic hospitalization, and I didn't have anything better to say to her than, yes, this was an incredibly traumatic hospitalization. Can you help us shift our illness scripts or sort of our spiels for families?
I think that acknowledging that it was extremely traumatic is probably really important, because especially for a teenager who is very cognitively aware of what they are feeling, but may be confused by it, may not be seeing external validation for it. I think that validating their concerns and feelings is probably really important. I can imagine that one of the struggles that an older child or teen may experience is themselves feeling completely traumatized and scared and angry, and everyone saying, it's going to be fine. You're doing great. Look, you didn't require a ventilator. Look, you're doing so well. And I don't know that we need to reassure them all the time. It may be reasonable to say, I get it. This sounds like it was really scary. Let's figure out how we can help you process that. And I think that that's where some of the literature that folks have done on these like post-ICU diaries and stuff may be helpful, because it actually gets kids and teenagers and families to process some of that.
Yeah.
I think that acknowledging to patients, if they're old enough to hear you or to understand you, and families that, yes, they're doing much better. Yes, we think that all of these things, their lungs, their hearts, their kidneys, what have you, are definitely getting better, is really important. Absolutely, we want to focus on those positive aspects, but also to acknowledge outright that the ICU is a scary place. They haven't gotten much sleep. They have met hundreds of people, none of whom they probably remember, and it may take some time to get back to their normal life, and that's okay. And that reaching out for help to get through that is also okay.
Oh, nice. Thank you.
I wanted to give you another opportunity to talk about how other members of the family or caregivers are also affected by post-intensive care syndrome. I would imagine that the parents or caregivers would suffer from anxiety, or maybe issues with lost time at work, or maybe siblings who maybe don't get as much attention from the parents as they would otherwise and maybe have developmental concerns. Anything really come to mind in that area?
Yes to all of those things. So we know that the impact of a hospitalization does not end with the patient who's hospitalized. We've seen it. Those families are at the bedside often around the clock. They are missing work and their own social supports. Oftentimes, two-parent households are split up so that one parent can be at the bedside and another parent can be taking care of other kids or other family members or trying to work so that the family can maintain some sort of income. And the impact of this on the family can't be understated. There have been multiple studies looking at PTSD in families, and there are extremely high rates of PTSD for the family members. The economic consequences are not minimal, and the impact on the siblings is probably the least studied of all of these areas. On the one hand, the presence of siblings may be able to support a child in getting back to their normal routines. On the other hand, a child who's been hospitalized for a long time with a lot of attention to them, you could certainly foresee may have an impact on that child. There's probably been more work in that area among siblings of patients with chronic conditions like cancer. And the impact on siblings for that. And I think it is important that we in the ICU community start to acknowledge that as well, especially as at many institutions, siblings are no longer allowed at the bedside, or at least have not been allowed at the bedside nearly as much over the last few years. The PICS-P study is looking at parent outcomes and sibling outcomes. Other studies that myself and others are doing are trying to look more and more at things like parents' quality of life, PTSD, family functioning, family economic consequences. It gets harder to think about how we as pediatric intensivists can then support parent emotional or economic consequences. That is getting even further from our area of expertise than child post-ICU morbidities. And even from a hospital standpoint, a lot of the resources that hospitals have or healthcare systems have is to support the patient. And with more and more documentation of the impact on families, then hopefully healthcare systems as a whole can start to think about how the support for family gets incorporated into that. It's, at least in my experience, rare for a pediatric institution to have a lot of support for a non-pediatric patient. And I think it's reasonable to consider that the parents may be, in some degree, considered a patient themselves with that impact. And as more and more literature comes out to support that, it may help with hospitals incorporating things like rehab psychologists or more social work support for the families. We probably don't have a clear mechanism to help the caregivers, the primary caregivers of parents. So, for example, their primary medical providers. That I think is unlikely that we as an intensivist or even as a inpatient provider on the floor would ever get in touch with a primary care provider for a parent. And so I think that that information has to go directly to families in some way of saying, we know that this has been hard for you. It is not abnormal for you to be suffering from this illness as well. Here are some thoughts about resources, or even if we're not that far, if you are struggling, please reach out to your own healthcare team to do that and to be able to empower them to do that and not just focus on their child's recovery, but also focus on their own recovery as a mechanism to help their child recover as well and their whole family.
Excellent. Dr. Killien, thank you so much for joining us today. I feel like this episode for me was galvanizing, and I'm sure that's going to be true for the people that listen. Is there anything else you'd like to add or any take-home points you want to leave our listeners with?
Yeah, I think that from the perspective of a resident or a fellow who's getting in this role, I think that who's thinking about the post-ICU outcomes of their patients, I think it can be easy to see that as a lower priority than just getting through the day, which is oftentimes how the day-to-day life of a fellow in the ICU is. But when you have the opportunity to talk to a family, especially towards the end of their hospitalization, think about trying to incorporate some of the talking points about they may be at risk for these types of things. It may not just be limited to their physical functioning or their pain. It may continue on to their emotional coping, their sleep, their sense of worry or comfort in their environment, their interactions with their peers. Counseling families that if they're noticing any of those things, to please bring it up with the child's healthcare providers can be a really nice first step from a clinical standpoint of how we start to incorporate the idea of post-ICU morbidity into our daily routine until we know more about other interventions that can be helpful. And then from a research standpoint, if fellows are interested in getting involved for their own research or academic interests, I would encourage them to connect with some of the larger organizations like SECM or PICS-P, because doing post-discharge outcomes research as a fellow is really hard because you, by definition, need some longitudinal data. And so connecting with folks who already have collected some of that data can be a nice way of being able to do a study on post-discharge outcomes without it taking your entire 3 years of fellowship just to collect the data.
Nice.
Dr. Elizabeth Killien, as Alice mentioned, I've learned so much. We really appreciate you spending your time with us today.
Thank you so much for having me.
And thank you for listening to this episode of PICS-Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review in your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.
Zach, you know what I feel like our listeners, I just feel like they should know. I can't put a finer point on it. I just feel like they should know.
Let's hear it. What is that?
I don't know if our listeners know that you have 3 kids. Would you be willing to share that with them?
I can't imagine they haven't heard them scream in the background at many of our episodes previously.
I don't know. I feel like well, okay. I would like to let our listeners know that you have 3 kids.
3
I feel like
rambunctious kids. Living life
weird?
one day at a time.
Yes. Living life.
Perfect.